Thanks to the Women's Health and Cancer Rights Act of 1998, insurances are now required to cover for breast reconstruction after a patient has a mastectomy. A mastectomy, of course, is a removal of the breast or breast tissue, typically done because a patient has breast cancer or is at risk of developing breast cancer and opted to prophylactically have their breasts removed. But actually, only 44% of women who undergo a mastectomy opt to have reconstruction done. And typically the reasons are because they are afraid that the cancer might recur and it might not get detected, or they may just not know about their rights regarding reconstruction. As someone who specializes in plastic and reconstructive surgery coding and even has the plastic and reconstructive surgery coding credential, I've coded a lot of breast reconstructive services and even corrections in my career. And since October is Breast Cancer Awareness Month, I could not go through this month without doing some presentation on breast reconstruction coding. Now, when it comes to breast reconstruction coding, there's two very important things that we have to think about. First off is our laterality, because when we're talking about breasts, we're thinking about, is it bilateral, unilateral, is it RT-LT modifiers, and even in our ICD-10 CM codes. When we're going to that table of neoplasms and finding the correct code, we need to know if it is impacting the right breast or the left breast. In some cases, a patient might have right breast cancer, but is also having the left breast removed, and we need to have the proper code assignment for something like a right breast cancer, including things like the quadrant if known, and then that the left breast did not have cancer, but we're removing it because that patient does have cancer in the other breast, so this is being prophylactically removed. We don't want to incorrectly code for the wrong size because that will look possibly like the cancer might have spread, and we also don't want to diagnose a patient with breast cancer when they're actually just at high risk and are having one of those prophylactic removals. Now, one of the problems I used to run into as a plastic and reconstructive surgery coder was getting that specificity of the quadrant and exact location of the breast cancer. Commonly, plastic surgeons, they just know it's covered for breast cancer, so they'll just put breast cancer as that diagnosis code. I've even had plastic surgeons say to me, hey, I'm not the oncologist. When I get in there, the breasts are already removed. I don't know where the cancer is. So it's often a point of education for providers to say, hey, even though you might not know what quadrant that cancer was located in, you can likely see that from the EMR, and that needs to be that definitive diagnosis you're putting in your operative report, because every operative report stands alone. Just because the diagnosis was put on during maybe an office visit or during another operative report, maybe from the general surgeon or breast surgeon that removed the breast, that has to be documented in that plastic surgeon's note that's doing that reconstruction. And it's really important to have that diagnosis correct, because those breast cancer diagnoses, they typically like to see them in that primary, that number one listed spot, because that's what insurances are going to look at on the claim form to make sure that that medical necessity is there to cover the reconstruction. So if insurance looks at that and they see that the first listed diagnosis is acquired absence of breast, they're probably going to look for a breast cancer diagnosis. So sequencing can really come into play there. Now, when it comes to reconstruction, there's two types of reconstructive and two big words we need to know as coders: autologous and non-autologous. Autologous means we're using the patient's own tissues and reconstructing it to form the shape of a breast. Non-autologous means we're likely using an implant. With our autologous codes, we differentiate between the free flaps and the pedicle flap. So a pedicle flap is something where they might take like your tissue from your abdomen or your back, keep it connected via a vascular pedicle, and then rotate that tissue into the breast and reattach it there. During a free flap, they're completely transecting it and then doing a microvascular anastomosis. There are certain types of procedures that have to be done by a trained microvascular surgeon, and they are extremely labor intensive to do the free flaps. But some patients really like those free flaps because they can do things like transect tissue from the abdomen and form that into the shape of a breast. So the patient gets a sort of almost tummy tuck effect, but it's a pretty labor intensive thing. So it is a long time that that patient has to be in the OR for that reconstruction. So they have to be an appropriate candidate for that procedure. If you grab your CPT book, actually your breast codes are in the integumentary section, and they're all in that 1900 series. And you can see there's a lot of different guidelines pertaining to breast reconstruction. So for example, our 19364 is our microsurgical free tissue transfer, and that's for things like our deep flaps, our gap flaps, and our F-trams. And then we have codes 19367, 8, and 9 for our different pedicle flaps. One of the more common forms of reconstruction is actually to stage it and do a placement of an implant. There's different types of implants such as saline or silicone. In our saline implants, if there is a rupture, the body will naturally absorb all that saline, but then the breast will deflate. In the silicone implants, if they accidentally rupture, that material still stays in there, so the breast may take on a different shape, or it might have complications because of that rupture, but you won't have that deflating like you will in the saline implants. And because they're done in stages, we as coders have to look out for those 58 modifiers. So typically what's done is the patient will have their mastectomy, and the plastic surgeon will go in and place a tissue expander. And that tissue expander will be slightly inflated at that time of the surgery. And what it will do is the patient will go into that plastic surgeon periodically to have the tissue expander expanded. They'll pump it full of saline to stretch out that tissue so that it's then stretched out appropriately to place a permanent implant in. And then after that, a lot of patients will also have nipple reconstruction done. So sometimes they'll rotate the skin, or they'll have nipple tattooing done to simulate that image of a nipple. So first we have our 19357 for that insertion of the tissue expander, and then all those expansions that they have in that 90-day global are included in that code. Now, there were actually some changes this year to coding for that exchange, where we're taking out that tissue expander and placing in a permanent implant. So what happens is a lot of times with tissue expanders or breast implants, they can develop what they call a capsule, which is like this hardened tissue that forms around that implant. So when we're removing that tissue expander, oftentimes there's going to be a little bit of a capsule that is formed around it. So in the code for the exchange, which is 11970, there's expected to be a little bit of removal of that capsule. But if they're doing an extensive capsulectomy, which has to be very clearly documented as extensive, like there were multiple incisions and extensive work to remove that capsular contracture, it states in CPT Assist from September of 2021 that extensive revisions to the capsule at the time of the tissue expander to implant exchange would be reported separately with code 19370, which is revision of peri-implant capsule of the breast, including capsulotomy, capsulorrhaphy, and or partial capsulectomy, in addition to that 11970 code. And then it goes on further and says if extensive capsule and extensive soft tissue work is performed, not just revising the scar or removing a little bit of skin to get it to look nice, but in that case, where we're doing an extensive soft tissue work, we're going to report code 19380 instead of 19370, because the work of that capsulectomy is included in that big revision code, the 19380. And that 19380 would be reported in addition to the 11970 for that tissue expander implant exchange code. So now we've had stage 1, which is the insertion of the tissue expander. Stage 2 is we exchange that expander for a permanent implant. And then the potential third stage would be the patient has a nipple reconstruction. So nipple reconstruction is often done by a skate flap. So they take a little bit of the tissue, kind of rearrange it into the shape of a nipple, and then included in that is tattooing of that nipple to get the pigmentation right. Now, some patients, they don't want to have that third stage. They don't want the little flap to have the nipple created, so they just go for the tattooing. Some patients actually prefer to have that done out of pocket because there are special tattoo artists that are very, very good at creating the 3D color of that nipple. Of note, there are codes specifically just for tattooing, so if they're doing tattooing just of the nipple, you can bill for that if it's done without doing the flap. Now, if you're interested in learning more about the tattooing, you can check out this video here. I'll also link it in the description below so you can find out more about how to bill for that tattooing service. So when we're coding for these reconstructions, be careful about those RT-LT50 modifiers. You want to make sure that you're assigning them appropriately for what's going on, and also that the provider documentation supports that both breasts were reconstructed. Sometimes a provider will do a very good detailed operative report for one side, but then forget to say that the mirror procedure was done on the opposite side. So you can't really tell sometimes between the right or the left if both were done. So in those cases, you will have to send it back to the provider to provide an addenda to say, you know, that mirror procedure was done on the opposite side, because we can't just assume that because the patient had one breast reconstructed that they did both. And sometimes you will see differences in what they do on one side versus the other, or they might develop complications complications later on that are just on one side of the breast versus the other. Now, today I'm not going to get too much into complications. If you guys are ever interested in me putting together a paid webinar that would cover the entirety of breast procedures from a plastic surgery standpoint, I can certainly put that together. Definitely let me know in the comments below. I will see you guys in the next video, and until then, just keep on coding on.